Welcome back to the deep dive. We've got an incredibly important topic today, really fundamental stuff for understanding the human body. Okay, let's unpack this a bit. Imagine your body, right? Inside, you've got, what, about 5 liters of blood? It's this vital, life-sustaining river just constantly flowing, getting oxygen and nutrients out to every single cell. It's really a miracle of constant movement when you think about it. But here's the body's incredible tightrope walk, the real dilemma. What if that vital river suddenly, I don't know, turned to stone, just solidifies spontaneously inside your circulation? You'd have catastrophic clots blocking everything up. Or, flip side, what if any tiny crack in the riverbanks, any little vessel break, led to an unstoppable flood? No way to stop the leak. It's yeah, pretty terrifying thought either way. So today we're diving into the body's really ingenious system for managing these two extremes. Our focus, haemostasis and thrombosis. And this deep dive is really crafted specifically for you. Maybe you're a first-year medical student, to help you not just, grasp these crucial concepts, but actually retain and recall them.
That's a perfect way to frame it. It really underscores just how critical this delicate balance is for survival. And this isn't just like abstract theory you learn in a lecture hall. This is the biological marvel that stops us bleeding out from a paper cut, but also prevents, life-threatening things like heart attacks and strokes. Without this incredibly precise dance of pro-clotting and anti-clotting forces, well, life just wouldn't be possible. So our mission today basically is to explore these intricate processes. How the body stops bleeding, that's hemostasis, how
Awesome.
clots form when they shouldn't, thrombosis, and importantly, the clinical side, what happens when it goes wrong. We'll use some clear analogies, hopefully some memorable anchors, to help these complex ideas really stick. And actually, here's something for you to ponder as we go through this. What specific triggers might push the system too far one way or the other? What could lead to that sudden, unwanted dam of a clot? Or conversely, that catastrophic flood of bleeding? We'll definitely circle back to that.
All right, sounds good. Let's start with hemostasis, and then the official term for how your body stops bleeding. It's a beautifully orchestrated process. For simplicity, let's think of it in maybe 3 main phases, like a rapid response team that then calls in the construction crew, and finally the cleanup crew comes through. We can maybe call it the PSD system. Makes it easier to remember. So first up is primary hemostasis. This is the really rapid formation of an unstable platelet plug. Think of it like quickly jamming your finger over a small leak. It's a quick initial patch just to get things under control fast.
Right, the first responders arriving on scene.
Exactly. Then second is secondary hemostasis. This is where the body really brings out the, let's call it super glue and mesh. It makes that temporary plug permanent and strong. It's all about stabilizing that platelet plug with something called fibrin, thanks to the really powerful blood coagulation system.
The heavy-duty construction crew, basically.
You got it.
Okay.
And finally, dissolution of the clot and vessel repair. So once the damage is fixed, the body needs to tidy up, right?
Mm-hmm.
This involves fibrinolysis, that's dissolving the temporary patch, and then recanalization, basically reopening the channel to restore normal blood flow, the cleanup.
PSD, primary, secondary, dissolution. Nice.
And to make all this PSD stuff happen, there are 4 core components working together. You've got the vessel wall itself, the platelets, the coagulation system, and the fibrinolytic system, the clot busters. It's a real team effort. And, any weak link in this chain, any defect in one of these components can lead to problems, either too much clotting or not enough.
Absolutely. And these components, they really do work in concert, like you said, like a well-drilled emergency crew. Take the vessel wall, for instance. It's not just a passive pipe. When it gets injured, it immediately constricts vasoconstriction to limit blood loss right away. And crucially, its inner lining, the endothelial cells, they release something called von Willebrand factor, or VWF. That's absolutely key for starting that primary platelet plug we mentioned. But, and this is really important for understanding the balance, normally when the vessel is intact and healthy, these same endothelial cells actively prevent clotting. They produce substances, inhibitors, things like heparin-like molecules, thrombomodulin, nitric oxide, prostacyclin. These stop the coagulation system kicking off unnecessarily and stop platelets sticking when they shouldn't. So the vessel wall plays this dynamic dual role. It promotes clotting when needed, but actively prevents it when everything's okay, maintaining that critical balance.
Okay, so let's zoom in then on the platelets. These tiny enucleate cells, meaning no nucleus, which is kind of weird. They're the real unsung heroes of that primary hemostasis, aren't they? They're like microscopic first responders rushing to the scene of the injury.
Absolutely. Tiny but mighty.
Yeah. So, quick facts. They're small, only live about 7-10 days, made in the bone marrow, their main job, maintaining vascular integrity. And they just spring into action the second a blood vessel gets damaged. That formation of the primary plug, it involves basically 3 key steps. First, adhesion. The platelets have to stick to the exposed bits of the damaged vessel wall.
Getting a foothold.
Right. Second, aggregation. Once they're stuck, they call their buddies over, sticking to each other, forming a cluster.
Safety in numbers.
And third, plug formation. They build up this temporary plug. Now, here's a simple anchor for you to remember this bit. Think of VWF, that von Willebrand factor we mentioned. Think of it as the Velcro that helps platelets adhere to that damaged vessel wall.
Ah, Velcro. I like that.
Yeah. Without VWF, the Velcro, platelets just can't get a grip, and that initial plug just doesn't form properly.
And that's exactly why the next stage, secondary hemostasis, is so vital because, like you said, that initial platelet plug is still quite soft. It's unstable. It's a decent temporary fix, sure, but it's probably not going to hold up against blood pressure for long. It definitely needs that reinforcement, right?
He's the super glue.
It does. So what is this super glue and mesh exactly? The stuff that stabilizes the plug and makes it really robust. How does the body actually produce it?
Okay, that leads us perfectly to the big guns. The coagulation system. This is essentially our body's amazing fibrin factory.
Fibrin factory, good one.
It's not just one simple step, though. It's a cascade. A whole series of inactive proteins called factors, usually written with Roman numerals, they get converted into active forms, one after the other, in a specific sequence. And the cool thing, or maybe the scary thing, is this cascade allows a tiny initial trigger to create this massive amplification, a huge clotting response very quickly. Think of it like a carefully set up line of dominoes. One tips, and the whole chain reaction goes off, a domino effect.
Exponential amplification.
Exactly. Now, to help you navigate the different parts of this cascade, let's use a simple acronym, IEC. It stands for Intrinsic, Extrinsic, and Common Pathways. Now, the extrinsic pathway, think of E for external. It's your external alarm system. It gets kicked off by trauma, actual tissue damage outside the blood vessel that exposes something called tissue factor, or factor 3.
So a major injury, for example.
Right. Then you have the intrinsic pathway, think I for internal. This is your internal alarm. It's triggered by problems within the blood vessel itself, like damage to the endothelial lining, activating factor 12.
Like damage from atherosclerosis, maybe?
Precisely. And then both of these pathways, the extrinsic and the intrinsic, they converge. They meet up at the common pathway. This is where they both work to activate factor X. And from factor X onwards, it's the shared route. The simplified core of that common pathway is prothrombin gets converted into thrombin. Thrombin is like the master enzyme here. Thrombin then takes fibrinogen, which is soluble, and turns it into fibrin, that strong insoluble mesh. That's our superglue and mesh that locks the platelet plug in place.
And what's really fascinating, truly remarkable about thrombin is that it's not just the final enzyme converting fibrinogen, it's also this incredibly potent activator itself. It actually circles back and feeds into the intrinsic pathway. It activates other factors like factor 3, which stabilizes the fibrin mesh, and it even activates platelets directly.
Wow, so it amps up its own production.
Exactly. It creates these powerful positive feedback loops that just massively amplify the whole clotting signal. It's brilliant for stopping a bleed super fast, but it also highlights just how incredibly powerful this system is. I mean, think about this. 1 milliliter of blood has the potential to generate enough thrombin to convert all the fibrinogen in your entire body into fibrin.
Oh.
Yeah, which just underscores the absolute necessity for incredibly tight regulation. You need powerful off switches to prevent total chaos, right?
Absolutely. So you need brakes as well as an accelerator.
Precisely. So remember that question we posed earlier about what specific triggers might lead to a catastrophic clot? Well, now you can see it more clearly. It's either a significant external trauma exposing tissue factor kicking off the extrinsic pathway, or it's internal vessel damage triggering the intrinsic pathway. Those are the main ways this incredibly powerful cascade gets set in motion.
Okay, that makes sense. So what are these off switches then? The brakes?
Good question. The body has key natural anticoagulants. First, there's antithrombin III. Think of it as a major brake pedal. It directly inhibits thrombin and another key enzyme, factor Z.
Okay, antithrombin III. Got it.
Then you have protein C and protein S. These are also really important. They actually get activated by thrombin itself, sort of a feedback control. Once activated, protein C, with its helper protein S, goes around and essentially chops up and inactivates some of the cofactors needed for clotting, specifically factors VA and ACA.
So they're like the cleanup crew. disabling the things that promote clotting.
Exactly. They're like the cleanup crew, making sure the cascade doesn't just run wild indefinitely. They help wind it down. And clinically, this is super important because if someone has a deficiency in these natural off switches, like they don't have enough antithrombin the third or protein C or protein S, they can develop something called thrombophilia.
Philia meaning loving, so clot loving.
You got it. It's basically a predisposition to forming clots when they shouldn't. The balance is tipped towards clotting.
Right. So if hemostasis is the body's emergency repair crew doing its job, then thrombosis is when that repair system goes into dangerous overdrive. It's creating an unwanted and often really dangerous clot within the circulatory system during life. That's the key distinction, right?
Exactly. Clotting after injury is normal physiology. Thrombosis, a clot forming inside an intact vessel, is abnormal pathology.
Okay, so to understand what predisposes someone to thrombosis, there's a really foundational concept everyone needs to know. It's called Virchow's triad.
Ah, yes, Virchow. Absolutely critical.
Yeah, it helps us identify risk factors. So think of it as the SVB triad.
Yeah.
3 key factors that, when they're out of balance, significantly crank up the risk of forming a clot. So the S stands for stasis of flow. This is when blood isn't moving properly, it's pooling or sluggish. Like during prolonged immobility, think long flights or bed rest, or in conditions like heart failure where the pump isn't working well.
Makes sense. Slow flow gives clotting factors more time to accumulate and interact.
Exactly. The V is for vessel wall intimate damage. Damage to the inner lining of the blood vessel. This could be from atherosclerosis, those fatty plaques or inflammation, or even direct trauma.
That damaged surface exposes things that trigger clotting.
Right. And the B is for blood constituent abnormality. This is also known as hypercoagulability. Basically, the blood itself is just more prone to clotting. This can be due to things like smoking, certain medications, pregnancy, the postpartum period, or those inherited thrombophilias we just mentioned.
SVB stasis, vessel damage, blood abnormality. It's a great way to remember it.
So speaking of stasis, remember that question from earlier? You often hear warnings about long flights and blood clots. What do you actually think? Do long-haul air journeys really result in more venous thromboembolism, or VTE? Let's hold that thought for just a moment longer.
It's a really relevant question, isn't it? And understanding Virchow's triad, the SVB, is so critical because it gives us, as clinicians, the framework. We can identify the risk factors in our patients, predict who might be at higher risk, and crucially intervene to prevent potentially fatal events. You know, clinically, it's also helpful to distinguish between clots forming in arteries versus veins. They tend to look a bit different and cause different kinds of problems.
Oh, okay. How so?
While arterial thrombi typically form in areas of high blood flow, often over ruptured atherosclerotic plaques. They tend to be pale, granular, and often show these things called lines of Zahn, alternating layers of platelets, fibrin, and red cells. And because they block arteries, they often lead to ischemia, lack of blood supply, and infarction or tissue death. The classic example is a heart attack, an MI, caused by a clot blocking a coronary artery or
So
stroke.
blocking the supply line?
Exactly. Venous thrombi, on the other hand, tend to form in areas of slower flow, like the deep veins of the legs. They're often softer, more gelatinous, and deep red because they trap more red blood cells. And because they block veins, they generally lead to congestion, swelling, edema downstream from the clot. Think of a deep vein thrombosis, a DVT, causing a swollen, painful leg.
Okay, arterial versus venous. Different location, different look, different consequences. Got it. Now, sometimes the thrombus doesn't just stay put where it formed. Sometimes a piece breaks off. And when that piece, that fragment, travels through the bloodstream and gets stuffed somewhere else at a distant site, we call that an embolism.
The wandering clot.
Exactly. And here's a crucial stat. Over 90% of emboli are actually thromboemboli, meaning they started life as a thrombus, as a blood clot.
Right, the vast majority.
So these wandering clots, these thromboemboli, they typically follow one of 2 main pathways depending on where they started. First, you have venous thromboemboli. These usually start in the deep veins, often the legs of the DVT. They break off, travel up through the big veins, through the right side of the heart.
And where do they go next?
Straight into the lungs. They get lodged in the pulmonary arteries, causing a pulmonary embolism, PE.
Which can be incredibly serious.
Oh, absolutely. It's a spectrum. It can range from causing minor breathlessness if it's small, all the way up to a massive PE that blocks like more than 60% of the blood flow to the lungs, which can be rapidly fatal.
A major medical emergency.
Definitely. Then second, you have arterial thromboemboli. These often originate from the heart itself, Maybe a clot formed in the left atrium because of atrial fibrillation or from damaged areas in the aorta or carotid arteries. These then travel out through the arterial system and can lodge in various organs. If they go to the brain, they cause an ischemic stroke or CVA.
Blockage in the brain's arteries.
Right. Or they could go to the kidneys, the intestines, or down to the legs, potentially blocking blood flow so severely it leads to gangrene.
So arterial emboli tend to cause problems related to lack of blood supply to vital organs.
Exactly. So now let's circle back and finally answer that question about long-haul flights.
Ah, yes, the DVT risk.
Yes. So are they a known risk factor for DVT? The answer is yes, absolutely.
It comes back to Virchow's triad, doesn't it?
It does. Prolonged immobility sitting in that cramped seat causes stasis, plus maybe some dehydration, lower oxygen levels in the cabin. It all contributes. So yes, long flights can definitely increase the risk of developing a DVT, which can then potentially break off and cause a pulmonary embolism, a VTE. That's why prevention, getting up, moving around, staying hydrated is so important.
It really is. And, it's important to add that while blood clots, thromboemboli, are by far the most common type of embolus, other things can embolize too. It's not always a clot.
Ooh, like
Well, you can get an air embolism, maybe from improper IV line management, or a fat embolism, which can happen after a major bone fracture, where fat globules from the marrow get into the circulation.
wow, okay.
There's also amniotic fluid embolism, a rare but very severe complication of pregnancy or childbirth. Divers can get nitrogen embolism, the bends, if they decompress too quickly. Even things like clumps of tumor cells or fragments of medical equipment can unfortunately embolize sometimes.
So lots of things can potentially travel in block vessels.
Yes, though thromboemboli are the main ones we worry about day to day. But this brings us to another key point, another question we touched on earlier. If these clots are forming, does the body have any natural way to actually get rid of them, to break them down? And when that natural system isn't enough, or when the clot is too dangerous, how do we intervene medically?
That's a perfect lead-in, because things do go wrong with this system. Let's quickly touch on just a couple of specific conditions where this delicate balance is truly disrupted. So thinking about too much clotting first, there are inherited conditions. Thrombophilia is one common one you'll definitely learn about is factor V Leiden. It's a genetic glitch, basically, where one of the key clotting factors, factor V, is mutated. And this mutated factor V is resistant to being switched off by that natural anticoagulant, protein C.
So the off switch doesn't work properly on that factor.
Exactly. The
Okay.
result, the clotting cascade stays active longer than it should, leading to an increased unwanted risk of forming clots, particularly DVTs.
An inherited tendency towards thrombosis.
Right. Then on the flip side, the bleeding side, the classic example is hemophilia, usually hemophilia A, which is a deficiency in factor VIII. Here, a vital clotting factor is either reduced or completely missing. So the coagulation cascade can't proceed properly.
The domino chain is broken.
Precisely. This leads to prolonged, often severe, bleeding. People with severe hemophilia can have spontaneous bleeding, especially into muscles and joints called hemarthrosis, which is incredibly painful and damaging over time.
Thankfully, we have treatments now, like giving recombinant factor VIII.
Yes, huge advances there. Now, there are a couple of other conditions that can be really confusing because they seem to involve both clotting and bleeding.
Ah, yes. DIC and TTP, always tricky.
Exactly. First, DIC, or disseminated intravascular coagulation. Think of this as consumption coagulopathy. What happens is, often triggered by something major like severe sepsis or trauma, the clotting cascade gets activated massively throughout the circulation. Tiny clots form everywhere in small vessels, but this uses up all the platelets and clotting factors faster than the body can replace them.
So you run out of the raw materials needed for normal clotting.
Exactly. So, paradoxically, even though there's widespread clotting in tiny vessels blocking blood flow to organs, the patient also starts bleeding spontaneously from everywhere else because they've run out of factors and platelets. It's catastrophic, clotting and bleeding.
A real nightmare scenario, like a factory going into overdrive, using up all its supplies, and then breaking down completely.
It's a good analogy. Then there's TTP, thrombotic thrombocytopenic purpura. This is different. Here you get platelet masses forming in small vessels, causing microclots. This uses up platelets, so the platelet count is low. That's the thrombocytopenic part. And patients get purpura, those small purple bruises from bleeding under the skin. But crucially, in TTP, the clotting factors are usually normal. It's more of a platelet problem, often linked to abnormalities in how von Willebrand factor is processed.
So DIC is widespread factor consumption leading to clotting and bleeding, while TTP is more about platelet clumps causing low platelets and bleeding, but with normal factors. Subtle but important difference. And the complexity of all these disorders really highlights why getting the diagnosis right is absolutely critical. We need lab tests.
Right, so how do we test for these things?
Well, first step is usually a full blood count, FBC, which will give you the platelet count, among other things. Very important. Then, for assessing the coagulation cascade itself, we have specific clotting screening tests. Two main ones you absolutely need to know.
Okay, lay them on me.
First is the PT, or prothrombin time. It's often reported as the INR, International Normalized Ratio, especially when monitoring warfarin. The PT primarily measures the activity of the extrinsic pathway and the common pathway. So think factor VII, X, V2, prothrombin, and I, fibrinogen. Here's your anchor. Think of PT as the parking ticket for the extrinsic pathway. It checks if things initiated from the outside are flowing correctly.
PT, parking ticket. Extrinsic, okay, I can remember that.
Good. The second main test is the APTT, or activated partial thromboclastin time. The APTT measures the activity of the intrinsic pathway, factors 12, 11, 9, 8, and the factors in the final common pathway, XV2. So for the APTT, think of all participants through the intrinsic pathway. It checks the factors normally found inside the vessel and the shared downstream path.
APTT, all participants, intrinsic and common.
Got it. Those anchors are actually really helpful.
Great, and remember that third question we posed about whether the body has its own clot busters and how we intervene medically.
Yes. Does the body fight back against clots?
It absolutely does. We briefly mentioned it earlier, the fibrinolytic system. This is the body's natural mechanism for dissolving clots once they're no longer needed. It involves activating a substance called plasminogen into its active form, plasmin. And plasmin is like a molecular scissors that specifically chops up fibrin, breaking down the clot mesh.
So the body cleans up after itself?
Ideally, yes. But sometimes that system is overwhelmed or the clot is too big or dangerous. And that's where we step in with medical treatments. Right, the drugs.
Exactly. For existing dangerous clots, like in a major PE or an acute ischemic stroke or heart attack, we can give fibrinolytic drugs, sometimes called clot busters. Drugs like TPA, tissue plasminogen activator, streptokinase, urokinase. These work by boosting the conversion of plasminogen to plasmin, essentially supercharging the body's own clot-dissolving process. They literally dissolve existing clots.
Life-saving stuff in emergencies.
Absolutely. But often we want to prevent new clots from forming or stop existing ones from getting bigger. That's where anticoagulants come in. These don't usually dissolve existing clots, but they stop new ones forming.
Okay, the prevention drugs.
Right. You'll study these in detail, but the main classes include warfarin. This is an older oral drug, anchor. Think of it as the vitamin K blocker. It works by stopping the liver from using vitamin K to produce several key clotting factors, 2, 7, 9X.
So it reduces the building blocks for clots.
Exactly. It's effective, but it's tricky. It has a narrow therapeutic window, lots of drug and food interactions, and requires regular blood tests, INR monitoring to keep the dose right.
Okay, warfarin, the vitamin K blocker.
Then there's heparin, anchor. Think of it as the antithrombin the third booster. It works by making the body's own antithrombin the third much more effective at inhibiting thrombin and factor ZOS.
Hoping the natural brakes work better.
Precisely. It comes in different forms. Unfractionated heparin, usually given 4V and needing monitoring, often with APTT, and low molecular weight heparin, LMWH, given by injection under the skin, which is much more predictable and usually doesn't need monitoring, often used as a bridge until warfarin kicks in.
Heparin, the antithrombin, the third booster.
And finally, the newer kids on the block, the DOACs, or direct oral anticoagulants, anchor. Think of these as the direct hitters. These drugs directly target and inhibit specific key factors in the cascade, either factor dia, like rivaroxaban, apixaban, or thrombin itself, like dabigatran.
So more targeted.
Exactly. The big advantages are they're oral, usually have fixed doses, don't require routine monitoring, and have fewer interactions than warfarin. The main downside currently is they tend to be more expensive.
DOACs, the direct hitters. Got it. Lots of options.
Lots of options, tailored to the specific patient and clinical situation. And of course, beyond drugs, simple prevention is key. Keeping patients hydrated, getting them mobilized early after surgery, using mechanical things like anti-embolism stockings or compression devices, and sometimes giving preventative doses of anticoagulants like LMWH or DOACs to high-risk patients.
Makes sense. Prevention is better than cure, as they say. So just to circle back really quickly, that thrombus, the clot itself.
Yeah.
Once it forms, what are the possible things that can happen to it? Just a quick recap.
Sure. Once a thrombus forms, it can have several fates. It might propagate, meaning it grows larger, extending along the vessel. It might undergo lysis, where it's broken down and dissolves, either by the body's natural fibrinolytic system or by therapeutic drugs. That's usually the best outcome.
Dissolving away.
Right. Or a piece could break off and travel, embolism, as we discussed.
The wanderer.
Or the clot could undergo organization. This is where inflammatory cells and fibroblasts grow into the clot, essentially incorporating it into the vessel wall like scar tissue. And finally, sometimes within that organized clot, new channels can form, allowing some blood flow through again. That's called recanalization. It might partially restore flow, but the vessel often remains damaged.
Propagation, lysis, embolism, organization, recanalization.
Okay. Understanding those potential outcomes is really vital because each one has different long-term consequences for the patient, and it helps guide how we manage them.
Okay. Wow. So what does this all really mean for you, listening in as a future medical professional, trying to get your head around these incredibly complex systems? We've covered a huge amount of ground today, haven't we? We navigated that incredible balancing act of hemostasis, the body stopping bleeds. We learned about the dangers when it goes wrong, thrombosis, the unwanted clot. We unpacked the critical insights of Virchow's triad SVB. We traced the paths of emboli, those wandering clots, and we explored the impressive array of diagnostic tests and treatments we have.
It's a lot, but hopefully manageable pieces.
Yeah, hopefully. You now have, I think, a really solid framework to build on. Remember the PSD system for hemostasis, the SEB triad for thrombosis risk, the IEC pathways for the coagulation cascade, and those testing anchors the parking ticket, PTINR, for extrinsic, and all participants, APTT for intrinsic comment. It's a foundational scaffold, really, something to hang more detailed knowledge on as you progress through medical school.
It really is foundational knowledge because as you start seeing patients, you'll realize just how often seemingly unrelated symptoms, maybe shortness of breath, or a painful swollen leg, or confusion, or chest pain, how often these can ultimately be traced back to some kind of disruption in this very delicate hemostatic balance we've been talking about.
It connects to so many areas of medicine.
It really does. And maybe a final provocative thought for you to chew on. Consider this constant battle the body wages. On one hand, you have the absolute immediate need to stop bleeding, to prevent potentially fatal exsanguination. On the other hand, you have the equally vital imperative to keep blood flowing freely everywhere all the time, to prevent tissues dying from lack of oxygen. What if? What if future therapies could somehow precisely dial in that balance? Imagine if we could develop treatments that could perfectly prevent unwanted clots without increasing the risk of bleeding. Treatments that could effectively eliminate those difficult trade-offs we currently face with many of our anticoagulants.
Wow. Personalized hemostatic control.
Wouldn't that be something? It's a fascinating challenge, I think, for the future of medicine and pharmacology.
A truly thought-provoking question to end on. Well, thank you so much for joining us on this deep dive into the complex world of hemostasis and thrombosis. Keep that curiosity alive, keep asking questions, keep exploring, and we'll catch you next time on The Deep Dive.